About the interpretation and what variations we see in ERG. So the variations could be physiological, technical, and sometimes pathological, as we just saw in that patient with neuronal disease. If you have taken the ERG at a different phase of the disease, you will get totally different things. So we should be aware of that. So there's a huge list of things that cause these physiological changes. I'll just tell briefly some of them. What Praveen just now said, that if you have children, then the ERG should be interpreted with caution. So I have seen so many children labeled as blind because the ERG was not recordable or the VP was not recordable. I don't know, there's some echo. Can we have the door closed or ye echo thoda kam kari? I don't know why that echo is coming. Okay. So the ERG does increase with age, and so we have to be very careful when we interpret. So if you get a good recording, it's good, but if you don't get a good recording, don't say that this is poor prognosis, ask for repeat testing at another point of time. So the age and ERG, you can see here that there is a change of about 100 microvolts by the time the person becomes older. The gender, there is higher B wave amplitude in women, and possibly this is because of the smaller axial length, and there could be a 30 to 40 microvolt difference. So in your normative data, it's good to have the males and females of different age groups. The refractive error, a lot of work has gone in myopia and ERG, and sometimes very difficult in our situation because we have a lot of retinal dystrophy, both RP and CSNB, to correlate whether this is a retinal dystrophy or it's just because of high myopia. Because you can see here, high myopes, they get very low amplitudes and low implicit times. And there's less work done in hyperopes, but we know that hyperopes will get more of high amplitude. But again, there's that's a good case studies to do. There is a lot of test-retest variability. Sandeep also talked about this. So to test once and then when we test again the same patient at the same time, even up to 25 to 50% variability can occur just because of test-retest variability. So ISO requires us to have at least 2 reproducible waveforms, but it's not necessary that the next time you check this patient you will get very close. The good thing about diseases is that in most of the retinal diseases, a pathological ERG is very different from a physiological difference because there not only the waveforms change and also the amplitudes and the implicit times change quite drastically, especially in diffuse retinal dystrophies. So just a reduction of amplitude should not tell us that there is a disease or the disease has worsened. There's also diurnal variation, just like for visual acuity and IOP, there's a diurnal variation. So if you're doing a study, then it's better to do it at the same time of the day as far as possible. We all know that if there's media haze, if there's a pupil which is not dilating, then you need to account for that because that can lead to longer implicit time and reduced amplitude. So if you are looking at somebody who has a uveitis and the pupil has got bound down, that itself will affect. And if there's silicone oil, please don't try ERG because it will most commonly come out flat. So ERG in a silicone filled eye is not going to give you any information whether that eye has potential for vision or not because oil is a poor conductor. The amplitudes increase when there's less pigment in the retina. So albinos actually will have very high amplitudes. We don't have good data on Asian Indians where they fall, but I think they should be falling in between the people who have white retina and a black retina, depending on from which part of the country they come from. Dark adaptation state, again, some people try to do shorten dark adaptation. So especially if you've looked at that retina with some imaging device, like FFA or light-based systems, then the ERG is going to come different. So try to do ERG on a day or time when you've not examined the retina. And if you want to take fundus photographs, you can take it after the test is done. Then of course we should always ask for any medications which change the blood flow, change the blood pressure, change the caliber of the vessels, then they can have profound influences, especially general anesthetics and other drugs. So we should account for these. Also patients who are on dialysis, they would have different ERG. Then coming to technical causes, I think electrodes are the most important. I have just put here as something like a blink artifact. So how do you know that it's an artifact? One, because it's not reproducible. So we've recorded twice and it has come different each time. And second, there is no ERG which comes so late. So both the timing and the non-reproducibility tell you that this is an artifact, and this is not a true waveform. Now electrodes which are closer to the cornea, such as the Burian-Allen or jet electrodes, will have higher amplitudes than what we use here, the Zari electrode or the DTL electrode. So it's very important for the fiber electrodes to be as close to the limbus but not crossing the cornea, so that you get better amplitudes. And of course the stimulus parameters, what type of machine we are using, what type of the light is coming, that would also matter. So that's why it's important to have your own normative data. You can use the machine data for some time till you build up your own normative data. So I already said that there could be pathological variations. For example, in sidrosis, where there's a localized sidrosis, you can see that the waveforms were good. But in advanced sidrosis, it became flat. So again here, this is a true wave, but this is a blink artifact because it's not reproducible and it's coming quite late. So we should, like this patient, he was referred as like he has very good response. This is not a good response. This is an artifact which is there. So again, patients who have cone dysfunctions, they will have a lot of these artifacts. They will keep on coming up and they will look like waveforms. And sometimes they can be reproducible also. So it's not that the patient can just blink at the same time every time. And you can have reproducible artifacts also, but the timing will tell you that this is not a true response. Now here we have a patient whom we are testing, and here you can see that it seems as if he's got a lot of responses. Now these are not responses, these are the 60 Hz line artifacts. This is all because there is not good grounding or there is no earthing, and so there is some response here which is abnormal, but we can see that it has got contaminated with the other line responses. So we should not measure these, and then we need to correct some of the things. So I think the causes of artifacts briefly are patient factors, like if the patient has eccentric or poor fixation, this is especially for the pattern ERG or multifocal ERG, or patient has eye movements, or there is orbicular contraction, or even cervical muscle contraction. So how the patient sits, whether their muscles are relaxed or not, if they are very tense like that, bound up, it can cause contamination of your recording. Then inadequate transparency of the corneal electrode, or if there's poor quality, like we are using Zari, but if it has frailed and it has become bad Zari, then it will not give a good response. If there is inadequate viewing distance, like patient is not using the refractive error or is not at the correct distance, then you will get artifacts. And as also if the patient is not sitting at the height where he is supposed to sit, but he is low down or up down, then you will not get the good recording. So these simple things the technicians can avoid. And then there are other factors, as I said, the electrical noise and the electrical field which is around them, and the high impedance. So every recording we should check the impedance first, make sure that the baseline is good, and then do the recording. So sometimes we use excessive filters. So when there's too much of response, we use filters to move these out, the waveforms. So this can sometimes artificially change the analysis. So it's better to treat the cause rather than just put in filters and do the averaging to reduce your artifacts. So I think here we are saying that just because there's a hot spice girl, we should be speaking the same language and make sure there's no artifact, and we understand the system and realize what it is telling us and giving to us. Thank you.